Hi, everyone, and welcome back to the Information Bottleneck. And today we have a great guest, Tanishq. He's the CEO and the co-founder of Sophont.AI. And hi,
Hi, thanks for having me. Yeah, excited to be here.
thank you for coming. And also Ellen. Hey, Ellen.
Hi, Ravid. How are you?
I'm okay. How are you?
I'm great, and it's a pleasure to meet you, Tanishq. Um, I just have to remark that your company's named Sofont, and I believe it even has the same colors of this old. I think it was an antivirus software that was installed on computers named like Sophis or something. I don't know if I'm misremembering this, but yeah.
Oh, I didn't know that. Okay, that's interesting. Yes. So font, yeah. I mean, I know I've people have mentioned how, it's the connection with some of the sci-fi terms and like from the three body problem, things like that. But this is the first time I'm hearing about this connection to an antivirus software, so that's interesting.
Wait, but why did you choose the name?
So yeah, the name it basically it comes from like a Greek kind of term of basically meaning a being that could reason like a human. So that's kind of referring to AI, of course. The term was yeah, my sister's the one who came up with the name, so she I guess found this term and thought it was a good fit for our company. So yeah, but I mean, yeah, I know. I guess it's a similar sort of reason why the name Sophon is for three body problem, and some other literature as well uses similar terms. So that's kind of the connection, I guess. But yeah, it's just kind of a Greek kind of for it's just a yeah, just means a being that can reason like a humans. Yeah.
I'm a big fan of Greek names. I'm personally having my return to playing the old historical Total War games, and so I joke with my wife, the masculine urge to go conquer, to go conquer like Rome or whatever, right? Whenever
Yeah.
I go off Steam, but because of that, I see all the like different Greek the loading screens that are quoting Greek literature, little
Yes.
excerpts. So, yeah.
Okay, so let's go to talk a bit about news. What do you think about the new advertisement that Anthropic just released about OpenAI? They are just laughing that they have ads in ChatGPT, and they say that like, no, we will never have ads. Trust us. Do you agree with this? First of all, what do you think about advertising in ChatGPT, and then what do you think about the laughing that Anthropic did?
Yeah, yeah. I think it's the ad was interesting for sure. I agree. Like, advertising in ChatGPT is not an ideal thing to have for sure. And I am not looking forward to when they do add that. I do think it is interesting that Anthropic is kind of targeting that because I guess that means that they are trying to basically say they will never add ads to their service, I guess. So it's like, I mean, are we going to see 3-4 years down the line where they do add ads and then the Super Bowl ad will look foolish in comparison? So it's kind of like they're already like limiting themselves because yeah, well, it's kind of to me it seems a little premature, but the ads were funny, so they were interesting and enjoyable, I guess. But we'll see how it plays out.
Yeah, and I actually completely agree with what you said. There were some commenters on Hacker News that saw this and are like, I can't wait to see that, 3 or 4 years from now, this on archive.org or Internet Archive now, when they, Anthropic, has investors of their own that basically say, actually, you do have to put ads in. So I really, I like that Anthropic is trying to do this whole persona of like, we're the good company, we're evil. And they actually kind of live the, like they walk the walk with this right at this moment. But I'm not convinced that their monetization strategy can survive without ads. Though it's also interesting because Anthropic is way less focused on consumer like traditional personal or consumer use of their models and is much stronger with enterprise AI or just enterprise usage. So I'm hoping that maybe they can be ad free for a decade or more, but not really convinced about that.
Yeah, I think also like there is so there are a lot of options, right? How to make ads for ChatGPT, right? Like it can be super personal and like, yeah, I'm writing something and then like it will be exactly what I'm looking for, and it will know, like it will take my history and it will adjust it only based on what I want and what I need. But I must say that like it may that I don't think it will be a good direction to go. Like I think people will react better if it be like general ads, and that like, yeah, it not be exactly what I need or exactly what I'm looking for right now, but it will be something that maybe like I did in the last month or something like that, and then it will not be so personal. So I'm not afraid. Oh, I will not freak out, right? That, oh no, they know everything about me and like can basically sell anything to me, right? So
Yeah.
yeah, I think it will be interesting to see which path they will choose. But yeah, we'll see.
Well, and
um
I'll also just quickly note that OpenAI, it seems to there's some idea of break glass in case of near bankruptcy, which is going for the NSFW, like boyfriend girl, AI girlfriend, AI boyfriend kind of thing. And OpenAI also is trying to do that, and seems would rather have earlier done that, but apparently is having problems with generating deepfakes. And Anthropic seems like the very last company that would ever do this. And given that the Platonic representation hypothesis, the idea that you train on like harmful outputs, you get, bad code kind of things, like the notions of bad are correlated with each other. I think that OpenAI has some serious trouble brewing in the next few months or years. And I think that Anthropic may very well be able to lean into this persona, but we all know what happened to Google's "Don't Be Evil," so let's hope that they can keep it that way.
Yeah, we can. We also can talk about XAI, right? It like now it's part of SpaceX, and I don't know. It's amazing to me, like it may be that there is something that I don't understand in these things, right? But it looks to me basically that Elon just wanted to get rid of all the debate that it has on XAI, right? After he bought, like, acquired Twitter for so much money, right? And merged it to XAI. Um, so I personally don't think that like XAI has something that it's a unique or something that can actually distinguish from other companies. Just waste of money.
I think it's
I
very interesting personally. I don't know. I think that yeah, I'm not as their models are, I don't know if like there's like on the model side they're, significantly better or anything. They just seem to be catching up and kind of maintaining the level of the other frontier models. But I think on the infrastructure side, that's where they probably shied a lot more, building out their own super computer clusters and just, their build outs are really kind of the speed at which they're doing that and is kind of impressive. So I think it's actually the hardware side of things that it's actually like them owning the full stack on the hardware side. Like that's actually kind of pretty impressive that they're able to do that. And I think that fits. I mean, it can make. I think that's the connection that you're trying to make with SpaceX is how it fits in with that. And I guess their goal is they want to like have this sort of servers in space, which I don't know if that makes the most sense to be honest. But I mean, if that's what you want to try, then XAI seems like it would be a good fit for that. But I don't know if that's the most. Yeah, I guess I haven't like looked into it because I've heard experts say conflicting things. Some experts say this is a stupid idea, while others say it's actually a good idea. So I don't know. And it's like Google is also trying the same idea, and then there's like a couple other companies that are exploring this. So it's like I guess maybe there is something to explore there. I don't know, but I think overall the funniest thing about this whole situation is how like basically the XAI investors are now they're already exiting from
Yeah.
it's probably the first frontier lab to that the investors are getting an exit, which is funny because it's also was like one of the latest to the field as well. So the investors got a pretty sweet sweet exit there. So I guess happy for the investors.
well, and
at the end, this is good thing. Like at the end, all the time, it's good to put money in alien companies because like it just use it for like the next company, and like the next company will acquire the current one. So for you, it's good, but it's kind of like, I don't know, pyramid schemes, right? That like every time like the next level just like buy out the previous one. So I don't know, as long as there are enough people that want to put their money, fine. But
And if you look at the balance sheets, actually, XAI and Grok were not making any money at all. They were just bleeding and burning money quite rapidly. Now, SpaceX, my understanding, is surprisingly healthy and actually has, I don't know if it's like profit, but serious revenue. So a lot of people also point out that they're definitely, exactly the kind of making money, like keeping it where investors who put money into Grok can make money. I also just want to quickly note that Elon's in the Epstein files and wants us to think that, oh, no, it's not, it's all fake. I wasn't there at the time. And then Elon's daughter went on Twitter and it's like, actually, we were there. Actually, these are real. So I think there might even be, I don't know if that has any connection at all, but I'm wondering if eventually Wall Street will start to punish CEOs for being nutty. And, but, we also see that Palantir's, rocketing up at the same time. So apparently maybe not.
yeah, I think the problems with Palantir is even more severe, right? That basically like this company make money out of like wars or like weapons, and very like I don't know, immoral scenarios. But yeah, I don't know. I don't believe that Wall Street will punish them based on these like on moral issues.
Yeah, yeah, and there's a few other things with Elon. First of all, you talked about the speed of the build out for XAI's data centers. That is something that shocked all the analysts, but a lot of it in a bad way, because most of what they built out with was H100s and H200s, and they spent billions on those, and at a time, after Blackwell had come out. So I think that long-term decision making will kind of bite them. And also, France just raided XAI offices because, fear of like the Grok deepfakes on XAI being like violating a whole lot of, cybercrime legislation, and especially connecting to the whole Epstein thing, and especially with him asking for the wildest parties circa 2012, 2013 after Epstein had been convicted. I'm sorry, but Elon's looking real guilty right now, or at least really suspicious about his personal stuff. And I think all of this is bad, like very bad for the bottom line of all these companies when their CEO has a very slim but possible chance of like being arrested, and for possible like extreme capital crimes.
Yeah. Okay. I just saw on Twitter, Andrew's Karpati, that he celebrated, like mentioned, 1 year for his vibe coding tweet that like he defined or like try um to explain what does it mean vibe coding, and he said something there that I think I really agree with it, that like a year ago, when he just defined it, the vibe coding was something that like, yeah, for side project, for a weekend project that you're doing for fun, and it's not so secure, and like there are a lot of troubles, and it can just very quick, if you need very quick like proof of concept of your ideas, you're using vibe coding. And in the recent years, like during the last year, it looks like the models become much better, right? And now everyone are doing this agentic engineering, and everyone are working with Claude Code or Codex or whatever, and it can define, like it can implement and can build much better, stronger, sure software. And I don't know, people are now these days, I think it's very common to say this is the future, right? Like we are doing something like almost in the next months or years. We will not program anymore, and everything will be just talking with models? What do you think about it?
Yeah, I don't know. It's a good question. No, vibe coding is definitely very interesting. I think you still need to like the thing is like you still need to specify certain aspects of what you're doing. Like to me, it just seems like it's a you still need to like quote unquote code, but at like a higher level now. So it's just like I feel like this is just kind of a natural progression of programming as a whole, right? It's just like you just go it's almost like you're just turning English into a higher level programming language. So you still need to like specify exactly what you want to do, and you need to have some objective. Yeah, but obviously now there's a lot of flexibility that in some cases you can delegate to your agent or whatever to explore different design patterns and sort of ways of implementing things. But yeah, I think for kind of production level use, you still need to have some sort of specification, and so that is kind of like it just will look like a different form of programming to some extent, I think. Um, but I think certainly for a lot of like um these sorts of like side projects or stuff like this where it's not maybe the most production level thing that you need, like certainly you could, I'm sure it's going to be the case where you can just prompt for it and it'll come out immediately. This like that I'm certain is like it's almost there right now, and within the next year or so it'll be fully there. So that for certain I think is the case. If it's like basically like building the software for like a full company or something like this or something like that, I think you need to have some more guardrails in place, some more structure associated with it. But at the end of the day, it's still going to be kind of programming in English almost. So yeah, that's kind of my take on it right now.
Do you currently use like Claude Code or an agent harness for the majority of your code, or Cursor or
Yeah.
old school IDEs, or what?
Yeah, I mostly use Claude Code at this point. Yeah, no, I really like Claude Code a lot. My path has been I was using GitHub Copilot back when it was released back in, was it 2021 or something like this? Used that for a couple years. Then I switched over to Cursor sometime like beginning of last year or end of 2024 or something like that. And then was using that for about a year, and then basically then I switched over to Cloud Code sometime last year. And yeah, no, I really like Cloud Code because yeah, you just need to ask what you want and it does it. It's like really it's pretty magical. But yeah, I mean you have to like then there's a lot of like I use it actually fairly basic way. I think there's like people have very sophisticated setups, and I have not done anything like this, and it's kind of impressive to see the setups that people have done. And so I need to still explore some of this, but yeah, I mean, it's just kind of like it's an iterative process sometimes with the Cloud Code setup that I have. I ask it to implement something, then see how it works, that whatever it's implemented, then whatever issues I'm having, I just ask it to fix that and it'll do it. And then it's an iterative process. So but it's a pretty fun process as well. And it's like, yeah, it's like you have this other sort of programmer that's working for you, doing things for you. And then you just ask it what you need done. But obviously, yeah, like the more details you can put into what you want, the better it is. So yeah, I've been also now seeing like all these workflows people have where they use Cloud Code for a lot of their personal stuff as well, and that's something I haven't done yet, but I hope to explore very soon because that's also really kind of pretty impressive that people like create their own like productivity systems and life management systems basically with Cloud Code, and I think that's kind of impressive. And so hopefully I'll try to do that soon as well. But yeah.
Yeah, I feel that like it's really good, and I also use it all the time. But I feel it like you need somehow like we will need in the next months or years like, some platform or like some unifying framework, right? Like all the skills. I feel that like there's so much redundancy, right? Everyone are building their own skills, and probably 99% of them are the same, right? So
Hmm.
I feel that like we will need this platform that can manage it and unify it. And now I want a skill of, I don't know, a reviewer or a skill of like data science or something like that. I just can tell Claude Code, use it, right? I don't need to build it from scratch.
And I was comparing Codex versus Claude Code. Recently, they've both added their own concept of skills. Codex with a whimper, and Claude Code here with a bang. In fact, right at this moment, if you talk to anybody on Wall Street in the investor world, they are all spooked about the idea, especially about legal tech and video games. The idea that legal tech software, LexisNexis, and some I don't know the names of all of them, but the idea that them and even the rest of the software as a service industry is over because of a combination of people vibe coding alternatives to it and the new skills.md, in particular the contract review. I went and looked at all of the skills offered through Anthropic right now. It's all markdown files. It all looks like it was vibe coded with their Claude Code. Basically, prompt is like, you're trying to create a contract reviewer. What would be the best definition of what you're supposed to do? And the fact that the market is just reacting so poorly to this, it seems like yet another DeepSeek moment of and indeed, at least with Codex, when I started looking at their skills, I saw a lot more like real code in there and things that kind of go beyond markdown files, which is surprising, right? Because I haven't found Codex to be better at really anything else. But at least OpenAI understands that whatever these integrations are in the future, they've got to involve some kind of real, actions that can be scripted or even GUIs, right? I saw actually limited amounts of image and video assets in the Codex version of the skills. So, yeah, things are changing, but also investors are much ado about nothing, right? Is the Shakespeare play relevant title.
But I'm interested to understand, what do you think? What will be the role of this type of coding for research? What do you think? Like, basically, we don't need researcher anymore, specifically in AI, or do you think like we will be the last one that will disappear? I can see good arguments for both sides.
Yeah, it's a good question. Yeah, actually, I'm maybe a little bit more pessimistic about I think AI research does have a higher chance of getting automated compared to some of the other fields. I think when I look at AI for science just generally, what I've noticed is a lot of the current research in that space is more focused on, kind of literature and proposing experiments and all these sorts of things. But obviously you still need to go and run the experiments, and you need that sort of experiment in the loop system. But that's only true for anything that's more physical and in the lab. AI is not in the lab and physical like that. Every AI is just code at the end. So I would say that AI is actually out of the different sort of research, AI for science kind of research directions. AI research is probably one that is more likely to get automated sooner than something like chemistry or biology or whatever. Yeah.
But what about other software engineers, right? People that are building actual real softwares. You think they will, from one hand, right, AI researchers are in the frontier, and they really, right, they are building these models, they are building these tools. So probably people will need them in order to push the frontier models forward. But from other hands, you don't need them. You can iterate over the results again and again in automatic way, but software is much harder to do it, right? Because you have users, you have real users, you have more complicated, distributed systems that you need to that you can't simulate fully.
Yeah, I mean, it depends on the use case. Yeah, I mean, if it is something that is involving users, then sure. But then it's the question is it really depends on the use case, because honestly, a lot of these systems that are involving users, right? The users are also maybe using AIs to interact with these tools, at which point it's all just AIs targeting each other, in which case everything can just be automated. So it really just depends, I think, on the use case that you're looking at. But I think in the limit, as we are automating things away, it depends on you may not even need to have the human interaction there. And if it's just all AIs interacting, then that is something that, you can simulate that perfectly fine. So yeah, I don't know. It's again, like what's going to happen in near term versus what's going to happen long term. And I don't know the timelines of what this looks like yet, but yeah.
And I think history echoes too. I was lucky as a little kid. I was actually kind of bad at chess, but really into AI. So I was racing chess engines. Very nerdy thing for like a 13-year-old to be doing back in the day. But I watched the development of chess engines go through all the same things LLMs are now, including benchmark cheating scandals. Rybka, for anybody that remembers, had a similar moment to Llama 4. And in my mind, I look at this as the time period in between the best, Deep Blue coming out and beating Gary Kasparov in 2001, I believe, or around there. And then what is the point where the best chess engine is better than the best chess engine plus Grandmaster? And I think it was between 2009 and 2013. So maybe somebody can correct me, but it was definitely well surpassed by now, to the point where, Magnus Carlsen will definitely reduce the ELO rating of my phone if I try to ask him to help. And that's a little bit concerning. But what's maybe a kind of silver lining of this is human players playing chess against each other is bigger than ever, even in a world of chess AI. If anything, they're the fact that you can have a real referee who can tell you live who's winning objectively has actually made at least watching it good. So maybe at least competitive programming survives. But I do worry I'm similarly pessimistic about my long-term, earning potential as an AI researcher, as you are.
Yeah. No, I think just overall, like entertainment and sports are basically the two areas that will probably like long term remain, because humans like to watch other humans do things, and humans think it's very impressive, but other humans do things at a very high level. Yeah, I think like that will continue. That's like, yeah, we all should go into entertainment, I guess, or something. Yeah.
Okay, let's talk about medical AI. And
Yeah.
what does it mean? Tell us why we need to care about medical AI, and what
Yeah,
is medical AI?
why do we need to care about medical AI? So I think, to me, medical AI is probably like the most impactful application of AI, basically using AI to improve medical care. Improve, it can be anything from, improving diagnostics to selecting better treatments to designing new treatments, or it could even be on some of the more administrative side of things and some of the workflow side of things, speeding up the workflows of clinicians, helping patients get access to the right medical information. So medical AI itself is a very broad term. But I think, there's lots of different ways that AI is being applied to have an impact, and it's through a variety of different ways. Basically, any type of AI model is being applied to medicine. That includes, of course, language models, but also computer vision models, time series models, tabular models. Basically, any sort of classical ML method or foundation model method has been explored and applied. And even some of these are built into some of the tools already being used right now. A lot of the the classical ML tools are certainly already being applied in medicine. Even some of these being used for diagnostics and treatment already, including some FDA approved products. So they're like a bunch of FDA approved AI tools at this point, but they're mostly based on classical AI methods. So a lot of imaging tools built on CNNs, for example. And so, yeah, I think now the next frontier is basically bringing foundation models into medicine. And so, of course, right now, the most progress has been made using LLMs for this. And kind of incorporating LLMs into various workflows. So, of course, on the consumer health side, at this point, everyone is using LLMs to answer their medical questions. This is yeah, I'm sure all of you have used it. Everyone is using it. Doctors are using it too for, helping them during their, every day as they're talking to patients. They ask alums for suggestions and advice and things like this. Like this is like they won't say that they are, but they are doing it. And then on top of that, there are a variety of tools that, for example, when you are transcribing the patient doctor conversations and then using that to generate notes and populate the electronic health records and then make whatever predictions or whatever downstream from that. So that's also, there's a variety of those tools out there that are being actively used. So maybe if you've gone to the doctor recently, the doctor will ask you, hey, do I have your permission to record, because they're using AI to do that. So it's already kind of being kind of implemented these days to have an impact. But I think the real promise of AI as a whole is really to help with early diagnosis and personalized medicine, and overall even going beyond that, even things like longevity and stuff like that as well. But basically, kind of having a proactive approach to health instead of the sort of reactive approach that healthcare is having right now. And that will be with the use of foundation models that can process a variety of different modalities from the patient, both imaging, lab tests, patient history, even of course variable data, even data from like all kinds of data sources will be used to basically predict what your health is right now and where it's going and how you can intervene to improve your health. So that is where the future is going. That will be made possible with AI.
What does Sofont specifically do in medical AI?
Yes, that's a good question. So Sofont is, I like to call it basically a frontier medical AI lab. So, in a sense, we're trying to, be basically a frontier lab like OpenAI or Anthropic, but for medicine. What we've noticed is that, of course, the future of medicine is foundation models, and basically what we believe is that any sort of medical AI application is going to be built on top of foundation models. But there are very few companies that are dedicated towards building the foundation models used for medicine. And so that is what we're focused on. Instead of just building general purpose foundation models, building foundation models specific for medical applications. And our vision overall is focused on multimodality. Again, as I mentioned, what we think is really important is being able to merge different modalities in medicine together and process all of that together. Because again, this is replicating what a doctor would do and going beyond what a doctor would do. But if you go to a doctor, they're looking at your patient history, they're looking at your lab tests, looking at your imaging tests. They have to look at all of that information before they make a clinical decision. And right now, the AI models are being developed for individual modalities. There are models that are developed for radiology. There's models developed for text. There's models developed for lab tests. There are models developed for pathology. But these are all like siloed models that are not interacting with each other. And so to me, that seems like that's the wrong way of doing things. You need to have one universal model that is taking in all the information and processing it together to make clinical decisions. And so that is our North Star. That is the vision that we're building towards. And so that is what we're working on right now. We are the approach that we're taking is that we're actually starting out with models with individual domains, and then we plan to merge them together, kind of like a late fusion sort of architecture, into a multimodal model. So that's the approach that we're taking. And so right now we're building models in the domains of neuroimaging, pathology, and clinical text. And so that's what we've been working on for the past year that we've been around. Another thing that we focus a lot on is doing research open source. So we actually release our models and publish papers on our work. And we have this broader open source research community called medARC. And we have a lot of different clinicians, academic researchers, AI researchers, and volunteers that are helping out on the research projects that we're working on and publishing with us. And that further accelerates the progress that we're making. But yeah, open source is actually a big focus of ours. We think that's actually really important in the medical space, where you need to, of course, have transparency and trust in what you're doing. So yeah.
And where do you get the data?
It's good questions. Right now, actually, believe it or not, all the data that we're using is public data. And so it turns out there's actually a decent amount of public data sets that are high quality. People have been exploring these data sets. It turns out you can actually really push the performance if you think carefully about what you're doing and about the AI algorithms, about data cleaning, about all these sorts of things. You can actually really push performance even on these public data sets. But of course, like private data sets is also important. And so, we are, looking to collaborate with academic medical centers and work with some of these groups to work with their data sets as well. And so we are in conversations with several different academic medical centers as well. And we have a couple of data partnerships already with some of them. But we aren't using any private data yet because we're already making so much progress with the public data sets. So we figure let's push it as far as we can on the public data sets before moving on to the private data sets. So that's the approach because, we've actually seen some of this research happening on private data sets. So for example, we were training pathology foundation models. And so pathology is basically when you take like a patient tissue sample, like, from a biopsy or whatever, and you put it on the slide, on a microscopy slide, and you view under the microscope and make a diagnosis. So that's the pathology, histopathology that is happening. And so people have been trying to use AI to obviously automate this and be able to process these sorts of images. And so there've been a variety of different foundation models trained for pathology, and a lot of them are trained on private data sets. Data sets that include hundreds of thousands of slides, even millions of slides. And we actually trained a pathology foundation model on just 12,000 public slides, and it basically was similar performance to these models trained on millions of slides. For some of the benchmarks, it was actually state of the art. And so it's kind of crazy when you think about it. It's like, I think there's this kind of bias that having like as much private data as possible is like, it's a big flex for some of these institutions and companies. But if you're not careful about how you're using that data, if you're not careful about the quality of that data, the diversity of that data, then there's no point. It doesn't matter like how much the raw quantity is not what matters. It's the quality and the diversity. All these other factors matter as much as well. And so, that's what we're focusing on understanding is how does the data quality and data diversity affect the performance rather than just raw data quantity. And based on that, we can then, obtain private data sets. But until we understand that, it doesn't make sense to just, kind of collect as much private data sets as possible. So we want to be as kind of thorough and systematic as possible.
And what do you think about like the data modalities? Do you think like so you're not like if you have a lot of as you have more and more modalities, right? Like you can be less and less experts in each one, right? Do you think this is something that necessary that now you will be like you need experts in radiology or some other domains? Do you think that this is something that like you can scale it up, or you can automate it?
So, I mean, I would say that you do kind of need expertise in the domains. I think that you need to have some understanding, basically, of like the unique aspects of that data modality, because these aren't just like they're not regular images, they're not regular text. They have different data structures. So, for example, this pathology domain that I was mentioning, the images are actually gigapixel size images. So this is like some of the images are like 300,000 by 300,000 pixels. Like that's the size of the image. And so you can't just take an off-the-shelf VLM to process that. You need to be able to carefully process this large image. You either are dividing up the image into smaller patches, or you may be using some sort of hierarchical approach of processing it or something like this. And so you have to have that knowledge of the domain to be able to design unique models, unique architectures for these models. Another domain that we're working with is the neuroimaging domain. And we have this, what's called fMRI data, these brain image scans. But it's actually, these are basically 4-dimensional data sets because it's the 3-dimensional brain scan, but there's also a time axis involved. So, again, there's unique structures involved there that you have to, keep in mind. So, I think you want to balance both the sort of scaling up of the architectures and the models and the data, but also the domain knowledge. And I think, what we see in the field is kind of people overly focusing on one or another, right? I think there's a lot of like medical people that try to overly index on their medical knowledge and expertise and, come up with all these heuristics and very like custom things of processing the data, and they don't like scale up the compute, for example. And part of that is just the constraints that they have. Like a lot of medical folks, they're at academic centers, they don't have any compute, so it's very hard for them to do any large scale research anyway. So they come up with all these heuristics and things like this, and but when you try to scale it up, it does not scale up well. So that's one side of the puzzle, and then on the other side of the puzzle, you have just like AI people who are just trying to apply a lot of compute to problems they don't fully understand. And then it turns out they are building models that aren't actually that useful for the actual problems at hand. So we're trying to be in the middle where, we of course identify and recognize that scaling is important, and we also recognize that the domain expertise is important, and we want to be kind of in this middle area of trying to take both into consideration.
So are you trying so are you getting like researchers or like doctors from these fields? Or like what do you prefer? Do you prefer AI researchers or people that have expertise in specific domain?
Yeah, so we work with both, right? We have AI. So basically, our team right now is mostly AI researchers, but we also talk heavily to doctors and clinicians in the field as well. So yeah, I mean, like especially part of our broader medical AI research community that we have various different clinicians that are in that community that we talk to regularly and that give feedback on what are the actual clinical problems that actually need to be solved and whether or not our approaches are addressing those issues. But I think a lot of the doctors are really passionate and excited by this, and so they are willing to help out if possible whenever they can. And then on top of that, we have this sort of open source approach and publishing and stuff like this, and so like doctors love to help out if they can be on papers and things like this. Like they also they're a lot of them are academics as well, and so they love to get on work with people to publish papers and stuff like this. So a lot of them are actually really willing to contribute and help out as well. And so that's been really helpful, is kind of building out this sort of medical AI research community, which I think it's probably like the largest online medical AI research community. So yeah, we have a lot of feedback from there, and then we also work heavily with AI researchers. So both both we have right now two other researchers working for us, and then of course my co-founder, and then we also just hired another researcher just recently. So I guess our team is a total of 5 people actually, and then we also collaborate with different academic groups as well, and a lot of them are either medical AI researchers or just pure AI researchers as well. So yeah, that's kind of how we work. Yeah.
So the medical domain has become very personal to me,
Hmm.
unfortunately, because I have family who's both my mom and my stepdad have become rapidly very sick. So I'm my stepdad actually has now colon cancer, and
Mm.
between stage 2 and stage 3, and my mom is recovering right now from and I'm sorry, I hate having to talk about it, but a leg or a foot amputation as a result of
Mm.
diabetes.
Yeah.
I'm just curious, what can Sofont do for them, if anything, right? Or at least for their doctors or for the medical practitioners around them?
Yeah, it's a good question. Yeah. So, a lot of the models that we're building, we hope that, like that they will be used by doctors and clinicians to improve the care that they're providing their patients. So, for example, we're right now in the process of developing a language model for medical applications for doctors that will help them, better provide differential diagnosis, better provide treatment decisions based on guidelines, clinical guidelines. Because at the end of the day, also a big problem these days is also just the fact that you know, there are the guidelines are changing very rapidly. The research is changing very rapidly. It's very hard for clinicians to keep up to date with the latest in the field, and that's very important to do if you want to give the best care to patients. So being able to help doctors with that is actually a very important problem. So that's one area where our models hopefully can help in that space. Another area is again on both on the diagnostic side but also on the treatment side. So especially with cancer, big part of cancer, there like just a couple of things that I think is important in the cancer space, because a lot of people talk about cancers being like, oh, like we're gonna find a cure to cancer, and that's what everyone is like talking about AI is gonna be able to do. Like, sure, maybe there is some way it's gonna happen in the future, and I think with all these sorts of drug discovery efforts and so on, that's certainly possible. But to me, that actually seems kind of a very it seems longer term to me because a big part of it is also you need to like a big limitation actually in drug development overall isn't actually even just the development of drugs, but it's actually testing the drugs. It's like I don't know if people saw recently there was this news of like, oh, there was like it was going viral on Twitter for the past week or something of this research team uh found a drug. They had a drug that cures pancreatic cancer in mice, and it was going viral on Twitter and everything. And everyone's like, "Oh wow, this is amazing!" And like, I mean, it is amazing. This is like great research, but I'm sorry to be a little pessimistic, but like basically every type of cancer has been cured like multiple times in mice. Doesn't mean that it'll actually work in humans. And so it's like the translation from animals to humans is a big challenge because it's also not just about like first of all, the question is like a lot of the mechanisms they may not translate as well to humans. There are other sorts of pathways that are happening in humans that may interact in unintended ways. There could be different side effects that could happen that even if the drug works, the side effects are too toxic that it's just not a feasible drug. There's so many things that could happen when you actually translate it to humans. So like this is the thing is like and the problem is like testing in humans is also very expensive and it takes a long time. So that is actually where the real challenge comes from. And so, there to me, like just like saying we're going to cure cancer is not like the right way of approaching it. I think there are two things that is actually more useful. First is actually trying to diagnose the cancer at an earlier stage. So that's a very important thing that I think needs to be explored further. And so that's something that we want our models to be able to help out with that as well is early diagnosis of cancer. Then the and then the other thing is actually personalized treatment, right? It's like not every not every chemotherapeutic is going to be successful for every patient, and so understanding the treatment response for a patient and predicting that ahead of time so that you can select the best drug for a patient. So that's another area where we think our models can be able to utilize our models for this. So actually, this is where pathology is particularly useful. So you take the sample from the patient of the tumor, you look under the microscope, and that is typically used to make diagnosis to basically understand how severe the cancer is and so on. But with AI can look at the cells and the organization of the cells, the shape of the cells, all of that stuff in the image, and be able to predict molecular features of the cancer type and also be able to predict the treatment response. And so that way, just from that sample, which is taken from pretty much every single patient, it's like basically a required step for diagnosis. But now you can utilize that same information to try to predict the best treatments as well for patients. So there's a lot of research in this space, and that's an area that we're also working on with our foundation models that we want to be able to use these foundation models that we're training to be able to do that as well. So that to me seems like a more practical and feasible way of approaching curing cancer than just saying we're going to find a magical drug to do so. And that's how, when I like to also say that I'm, working towards curing cancer, but I feel like this is actually a more tractable way of doing that rather than a magical drug to do that. Which, to be fair, maybe we might find that. I think we could potentially find that, but I think that it's a much longer time frame than what we're developing. Actually, could have a much nearer term impact, I would say, than finding this sort of drug. So yeah, that's my take on all this.
So I have a question. How do you see do you see this problem of medical AI more as like a classification problem that you insert, right? Like you train your model on a lot of data, right? Like kind of like supervised data. And then you have the new patient, you insert all the details that you have. It can be like, I don't know, in different time point or whatever, but like it's a bunch of details and you want the model to classify the with some diagnosis, right? Or you see it more as like personalization problem, LLMs, for example, right? In generative models that you train on very large amount of data, and then you want some subset, you want like, I don't know, just few samples to personalize the model and to have specific, it can be predictions or some suggestions for this specific person. How do you see it?
Yeah,
It
I
may
don't
be
think
that it may be that like you can say that it's the same for you, right? Like it also an option.
Yeah, I think of it more of like a prediction problem. Like you're predicting how a person's health kind of evolves over time, and understanding how specific interventions affect that, like that is kind of the way I would think about it, is like trying to predict, like even a lot of the models that we're exploring is like, yeah, predicting the survival of a patient over time, and if an intervention can affect that, and improve that. Like, so that's how I would kind of um think about it, less so as like a pure classification problem, yeah, like predict, like say you were classifying a diagnosis, is actually like classifying a diagnosis is still very coarse grained, and I think when you're trying to move towards more personalized medicine, you know, if you're staying at this sort of coarse grained level of a diagnosis is actually not good enough in my opinion. So yeah, like a person who has a specific diagnosis, they can um you know react to medications in various different ways. They may respond well, or they may not, and there's other factors that are involved that affect this. So there's a lot more nuance than just saying, you can classify. So if it is a classification problem, it would be a very large classification problem. But I think the better way of thinking about it is actually it's more of like predicting how the health evolves over time, and there's a variety of different biomarkers that you're predicting, predicting, of course, survival and progression. These are the sorts of things that you're looking at instead. Yeah.
And how do we handle the inherent subjectivity of medical fields? So I'll just give a quick example here of this. The major professional organizations, like even in the US and the EU, will constantly disagree on even small things. Just one that comes to mind is the role of, and sorry if it's a little gross, but digital rectal exams and the importance of giving them to men for searching for prostate cancer when they become like elderly. One side of it, I think the US side says, hey, you should be doing this every X number of years. And then in Europe, the argument, I believe it's in Europe, but the argument from at least one other very large professional association is that the majority of the tumors that you find are benign. And it's more of a when, not if, that men will get prostate cancer. And that the consequences of performing the exam tend to outweigh the benefits, at least in their opinion. So what I'm curious about is how does your company and even these foundation models for medical kind of reason with virulent and disagreements among extremely intelligent white coats in the field?
Yeah, I mean, I think a lot of this is a question of this is actually like basically a data problem, I would say. In terms of like it's like people are making decisions based on very limited data that they have, and also very limited fusion of data as well. In terms of like not they're looking at, again, a single sort of data modality, not considering the full picture of a patient and making decisions based on the full picture. So I mean, I do think like I actually do think AI can help in some respects. For example, like going to this problem of like detecting benign versus malignant tumors. Again, a problem can be like, often there's a problem of like, okay, do you need to have like a biopsy there to do that? Versus, can you just use imaging to detect it? And so imaging, of course, is completely non-invasive. Can you predict just from imaging, is it benign or malignant? And that's a problem that AI can help. And so I actually think like these are like this sort of like what if you're able to, then, yeah, if you're able to predict benign versus malignant, then maybe it's less of a concern to maybe do something more often or something like this. Like, it alleviates a lot of these concerns in terms of the intersubjectivity. Even like sometimes yeah, there's been some research that look at like, yeah, like again, trying to make a cancer diagnosis, looking at the pathology tissue slide under the microscope, and you have multiple doctors looking at those. They may disagree, but then with the AI, the AI often makes more accurate predictions if you can also, have the AI provide some sort of explainability or interpretability, and the doctors look at that. Then often the doctors will agree with that or even change their mind based on that. And so even sometimes, in some cases, I think in some cases we might even be moving towards AI predictions becoming more of a ground truth than what the doctors are saying. And so I think that's kind of a interesting area where I think doctors will, I don't know how doctors will feel comfortable about this, but this is what the field is moving towards, I would say. But yeah, I think this is a big problem for sure. So like disagreement between different doctors, and I think AI will certainly play a role in trying to alleviate those issues. But then on top of that, as we collect more information about a patient and using AI to integrate that as well, then that will also give a better picture. So I think also it's also about the data that we're collecting for a patient, and if there are ways of introducing new modalities or doing things in a different way, that can also alleviate this problem as well.
And what do you think is the role of AI in medicine around dealing with what I'm going to call quackery?
Hmm.
So examples of this, and I'm sorry if I alienate viewers or even people here, but examples are chiropractic, homeopathy, and at least the naturopathic people admit that they're, alternative medicine, and Chinese traditional medicine also, is willing to use terms like alternative, right? But
Yeah.
here's an example. I had a dental surgeon who removed all 4 of my wisdom teeth and then gave me and told me I needed to swish around what I later found out was homeopathic dental stuff. And I actually forgot to do it before I came in. And I didn't read the bottle before I did it. And they were like, oh, it's totally fine. And then, I actually, when I realized when I got home in extreme pain, right, that he had given me homeopathic stuff, I immediately, when I realized that I had somebody engaging in quackery, complained to my state medical board about this. And you know what they said to me? Well, homeopathic stuff doesn't have any impact. So he didn't actually do any negative things. So they basically immediately closed the case. So I'm
Well,
sitting just in complete shock and awe, and I realized the guy just made money because it was like $30 per bottle that he was selling this stuff for. But what do we do about quackery in medicine? I mean, it's everywhere, right? Even in a dental surgeon who otherwise appears to have performed, good dental surgery.
yeah. Yeah, that's a good question. I mean, to me, this seems more of like a societal challenge that, and kind of, something that needs to be solved at a system level rather than from a technical or AI perspective. I think that AI can certainly be useful for educating people about these issues. And certainly, I'm sure if you, searched up these, maybe you did actually, is you searched it up on like ChatGPT or something like this, then you get then you have some better perspective on these sorts of things. And I think, a lot of consumers are not as educated on this space, and don't understand the differences. So I think that's where AI is going to be more helpful, is more on educating people. But I don't know if like AI is not going to be able to take away that person's license, for example. That's not a thing that AI can do. That's, I think, on the societal level. So that's how I would think about it, at least.
And what do you think about uncertainty? If you go, there is the uncertainty. If you go to 2 different doctors, they will
Hmm.
probably, or like like high chance that they will give you different results, right? This is one type of uncertainty. And also there is uncertainty of the data, right? Like it may
Hmm.
be that there is no one answer to this question, or like to your case. How you deal with that?
Yeah, that's a good question. I mean, I think this is like still to some extent, I will say this is still an open research question, and I think this is also true for even just like language models in general, and just sort of yeah, nation models in general is how do they deal with uncertainty in the information that they're giving and in their outputs that they're giving as well, when there's different outcomes, the uncertainty there. So like, yeah, this is like an open question where, we don't know the full answer to this. And I think that the entire field doesn't know the full answer to this either. And, we are curious to see how the field is progressing. And, we would also probably contribute to that research at some point as well. But yeah, to be quite honest, I think it's just a question that we don't know the answer to just yet.
Well, and I actually worry, connected to both my previous question and Ravid's, I think a lot of people want to hear something like and for example, we have the big 3 AI systems that are all broadly like ChatGPT, Gemini, and Claude are all very similarly aligned to each other right now. And then you've got Grok way over there willing to tell you all sorts of nonsense conspiracy stuff. I'm worried that we'll have these foundation models in the future that have been possibly fine-tuned to give people what they want to hear rather than the correct medical advice. And I'm wondering if you have any idea of how we handle that situation.
Yeah, I mean, I think the goal here is that the model should be grounded in factual medical literature and in clinical guidelines. And so, yeah, this is a problem that some of the foundation models aren't always. That's not always the case. And so, yeah, I think like that is having that grounding and not hallucinating facts and information is very important. And so, yeah, especially. And even then, it's like when even talking about medical literature, it's also about like where that medical literature is coming from. It should be peer reviewed. It should be, maybe in some cases you want to make sure it's replicated studies, all these sorts of things. So this is the sort of kind of, and especially when the clinical guidelines is basically uh that's kind of where you are looking at. But even the clinical guidelines to some extent, a lot of it is just basically even some of them are not like fully grounded in like the most detail in the most accurate information simply because there's just not enough data on a lot of these cases, but that's the best that we can get. And so um like yeah, we want our models to just basically be following the clinical guidelines, and we don't want it to stray far from that. But of course in the future there may be better ways of doing this. But yeah, I agree. Like this is a an overall problem with the current models. If you look at like some of the medical tools, though, like they already have some of these implemented these sorts of grounding in papers and stuff like this. So especially a good example is Open Evidence, which basically that's the sort of tool that a lot of doctors will use. But basically, it is. When you ask a question, it is looking at a kind of trusted source of papers and so on, and citing them in the responses. But yeah, that's kind of the current approach that has been explored.
But just a quick one on that. Open Evidence is also the name of the competitive debate collaborative project of saving all their evidence to the cloud for like 20 years. And so every
Really?
time debaters search for Open Evidence, they find the medical. And I think every time the
Oh,
medical
okay.
search for it, they find the debate evidence side. So that's a fun name collision.
I did not know that. I did not know that. The name used to be the company used to have a different name actually. I think it was called Xyla or something like this, and then they changed their name to Open Evidence. I guess maybe the people of this Open Evidence project are not happy that they changed their name. It seems like. But yeah,
They don't care that much. It's just a fun thing that I've found
yeah.
it referenced before in the past.
Oh yeah, yeah. No, Evidence is a pretty big company now, valued at a few $1 billion at this point or something like this, and raising tons of money. I mean, it is actively used by a lot of clinicians at this point, and a lot of clinicians really like it. So yeah, it's a really interesting tool. I mean, yeah, hallucinations and these are all issues, of course, even on the front of like I know sometimes, I think a big part of it is like these models. A lot of these models are also just not designed well for medical use cases. So another example on the hallucination and uncertainty and things like this is sometimes these transcription software, um they may incorrectly transcribe the conversations, and then when it inputs incorrect information into the EHR's records and things like this. And this is a problem that sometimes happens. But again, part of it is because those models were likely not designed for medical use cases. And yeah, there needs to be more. It needs to be more accurate. There needs to be more guardrails. So sometimes this happens, but I think this will improve over time, obviously.
Do you think so for the long term? Do you think that like these models will replace doctors and humans? Because there is at the end, I think in medicine it's very like um you have that big problem that you need accountability, right? I need it.
Hmm.
I'm trusting my doctor that like he's the expert and I'm going in to do whatever he will say. So I
Yeah.
have someone to blame, right? At
Yeah.
the end, this is the most important thing, right?
Yeah.
Um, do you think like we can get something like that with models, or like also for the long term we will still have this doctor that will sign on it and say, okay, this is I'm putting my name on it, and this is my fault if something get wrong?
Yeah, again, I think this is more of a societal question rather than a technical question, and I think it really depends on. I mean, I think even like a legal question as this continues to grow. In fact, yeah, I think it's like I'm sure like to some extent, like it's a good question because doctors obviously don't want their jobs to be replaced, but they also don't want to get into trouble for something an AI is doing, and of course the AI companies don't also want to get into trouble for what the AI is doing. Nobody wants to get into trouble for what the AI is doing. So it's like I don't exactly know how this will play out in the future. Another thing I will note is that I think from a sort of interaction perspective, patients may prefer to interact with a human than an AI. But at the same time, the problem is that it is very hard to get access to a doctor. So there's also that balance that needs to be made. So yeah, I don't know. It's still kind of an open question. Like I do think like a lot of these AI tools will reach the capabilities or even beat doctors very very soon. The question is how will society respond to that, I guess. And on top and I think it's like not even just like reaching the capabilities of doctors, but like just even like the point is like these AI tools can discover and predict information that doctors themselves could not find in patient data, and that itself like is like the real like to me that's what's exciting because like honestly like I'm gonna be honest like I don't really find replacing doctors to be like the most exciting thing. I think like doing new things is exciting, you know, I don't know if you've seen some of these papers of like, oh, I can they can predict risk of cardiovascular disease from an eye scan, right? Like that's kind of crazy. I can, or you know, they can predict, or even like diabetes risk from an eye scan. Like there's all kinds of information predict. There's various other. I think they can even predict like diabetes from like an ECG. I don't quote me on this. There's a few different papers like this. If you like search up, I think the person, you know, if one of the key people who tweets a lot about some of these papers out there is this guy Eric Topol. He tweets a lot of these papers, and this is what he likes to call opportunistic medical AI because it's like discovering something new in an existing modality. And so he calls it opportunistic medical AI. So there's a lot of these opportunistic medical AI research that's going on, and then again, like pathology is another good example of this, where you can predict, you know, mutations and gene expression and all of these other like molecular features from a tissue slide. So you don't have to do the molecular testing. You don't have to do, you don't have to send out a sample for molecular testing, which often can be very expensive and can take a long time, but you can predict it directly from a tissue slide. And that can be used to inform clinical decisions. But a doctor cannot look at a tissue slide and say, that's the exact mutation this patient has in their cancer. Like that's not something a doctor can do, but the AI can do that. And that leads to a new way of making clinical decisions. And so that to me is more exciting, rather than just broadly replacing, you know, the existing capabilities. So that's what we try to work on instead. Yeah.
Yeah. So there was, I think it was a Nature paper recently that took different sleep measures, right? It like
Yeah. Yeah.
you record people that while they are sleeping, and then so they train it with like self-supervised learning, different
Hmm.
modalities, right? And then they try to predict. I think it was like 120 like medical conditions, both like some disease and things like that, and they showed that they were quite good. And the interesting part, they did the self-supervised learning. They just try to predict one modality from the other. This is how
Hmm.
they train it with self-supervised learning, and then they put on the top of it some classifier on this representation. So, what do you think? Do you think like this is the approach, or like do you think like we will converge to something that just give me data, doesn't matter if it's supervised or not, just give me as much as data that you can get, and we will just do self-supervised on the top of.
Yeah. Yeah. Pretty much. We're strong believers in self-supervised learning for this. Like our pathology foundation model was also trained with self-supervised learning. We used Dino V2 for this, and then we also one of the benchmark tests was predicting gene expression from the slides, and so we just had a linear head on top of the model and predicted that. So yeah, like this is a pretty standard approach that we are quite confident in as well. We've also done similar things for neuroimaging, looking at fMRI brain scans, where we used an MAE for that. So yeah, yeah, I think that's the way to go in terms of learning the representations for these domains, for these modalities, and predicting useful information from that. The only thing is, then the only other question is like, how do you merge different modalities together? And so the approach that I think is going to be valuable here is that you still have to train different encoders for different modalities, but then you do need and then you'll need a little bit of multimodal, like multiple modalities to train and kind of align the different encoders together. Because basically, yeah, you have all these different encoders that have their own latent spaces, and the question is, how do you align the latent spaces together? And so I do think there'll need to be a little bit of training on top to do that sort of alignment between the different latent spaces. But then once you do that, then you can have this sort of multiple modalities all mapping to a single latent space, and you can use that to predict whatever you need to predict. So yeah, that's the sort of approach that we're pretty bullish on and what we're focusing on.
And do you have a specific idea like how to align these modalities if you don't have, the same timestamp for the modalities?
Yeah, no, this is still like an open question for us, I would say. Yeah, we're still we still don't have the answer to that. I mean, if you have ideas, I'm happy to hear ideas, but yeah, I think
If one of our audience has specific
yeah.
ideas, you can send us.
But I think that the thing is that, right, we don't need to answer that question right this minute, because what we're focusing on is first developing strong encoders for individual modalities. Because at the end of the day, like, we will be limited by the performance of these individual modality encoders. So we first want to improve those significantly before building out that multimodality model. So that's the approach that we're taking right now. But yeah, maybe like we'll probably start working on the multiple modalities in 6 months to a year from now. So we have a little bit of time to figure it out. But yeah, we will need to answer those questions very, very soon, though. So yeah.
And DNA is a next token prediction problem, and you talked about personalized medicine, so that seems maybe you don't even have to switch modality. It's the same autoregressive text, but now it's strands of it's 4 different chemicals or something in DNA. I'm not a medical expert, but I'm just wondering, would you start with something like that where it's like a very I guess it's not, it's the same. I don't know if that's a different modality or not, right? Like, but
Consider it a different modality, to be quite honest, because again, there's certain properties of that is different from maybe regular text. For example, DNA it's very long, right? So it's a long context kind of modality, and on top of that, like, yeah, you do have to consider the long context because there are often like long range interactions that happen, because DNA in the body, like in a cell or whatever, it's like, it's not just like a single strand, like it like loops around and interacts and whatever. So there's actually a lot that's going on. And then there's like, even modifications to the DNA that happen. So it's like, it's not, I don't think it's as simple as, it's just like a plain NLP task. I mean, you can treat it as a plain NLP task and you can get quite far. But if you think about, again, developing different architectures and scaling that up, you can actually do even better. So there are there's a lot of research into developing unique architectures. They're often based on like state space models or different different like attention, like linear attention or things like this, to especially handle the long context. And so there's a lot of research into that. I think there's a lot of research coming out of Stanford, and there's a couple of startups that are exploring these sorts of ideas as well. Yeah, again, the model does start to look a little bit different from just a regular transformer. But so yeah, I would kind of treat it as a different modality. But again, that's goes back to the idea of you need a little bit of that domain knowledge to be able to make those decisions and train those sorts of models. So yeah.
So we almost need to finish, but I just one more question. What do you think, or like, what is the regulation in this space? Is there very strong regulation that you can't do anything, as we hear a lot from other companies? You think when we talk about AI, it's a bit less conservative?
Yeah. So it's certainly there's certainly various different regulations that yeah, you cannot just go and deploy any random medical AI model and into the clinic. I mean, there are certain use cases that are allowed without regulation, but a lot of them are regulated by the FDA, and so it's very interesting because like even some of these what I call clinical decision support systems that is allowed by the FDA to just be deployed without any regulation. So what that means is like these sorts of tools that doctors can use to that will suggest a diagnosis or something like this. And so you don't need to get approval for this, but what we need to make sure is that it only uses it's like only just text. And so it cannot, for example, interpret images. The moment you start interpreting medical images, that requires a separate regulatory process, for example. And then on top of that, you cannot like, you know, lead the doctor towards a single diagnosis. You have to like, for example, say here are the list of options, and then these are like the evidence for and against it or whatever. But you cannot like force the doctor to say, yeah, this is the exact diagnosis, whatever. You have to be a little bit, you kind of have to hedge your bets a little bit, because the problem again with the FDA is trying to be kind of reasonable about the regulation as well, and this is a very fast moving field as well. So the FDA is continually updating and evolving in terms of the regulation. But here, the idea again is just like you don't want to have this problem of automation bias, where often often when you are like, even though like the doctor is supposed to be the final, supposed to review everything and approve everything, they often just like it's easy for them to just go with what the AI will say, and they will not check it properly. So you want to kind of be careful of these sorts of issues. So yeah, the FDA is trying to come up with reasonable regulations that isn't necessarily hindering the progress, but is also making sure that the models are being safely deployed. So that's where you are these are the regulations that are being used. But basically, anything that comes with like medical images, that radiology, or even like ECG various different modalities that are out there, like those all need to get FDA approval, basically. And then on top of that, I would say like another area where like you don't really need FDA approval would be if you're working with like pharma companies or life sciences companies. And so there's a lot to do there as well. And so that's what we're also, looking to work with pharma companies, especially because there's a lot of stuff on the research side and on the clinical side, clinical trial side, and these sorts of things. That you can do without needing FDA approval, but it can still have a huge impact in the development and development of drugs and bringing it to the clinic and so on. So it's still a very impactful area to work in, but it doesn't necessarily need immediate FDA approval or anything like this. So yeah, there's different ways of having near-term impact, I would say, with AI in the medical and life sciences space. And I know like a lot of people I've talked to, when we talk about medical AI, a big thing that they're scared of is like, oh, it's going to take like 5 to 10 years for anything to happen. And they're very scared of this. So there are a couple of things to note. Like this is true for like developing a drug from scratch. Yes, it'll take like 10 years if you're developing a drug from scratch to actually reach the clinic and to reach patients. And so this is especially the problem if you're working in AI drug discovery. Like that will take a long time, because if you're trying to discover a new drug and with AI, then for that drug to go through preclinical, then clinical, and then FDA approval, that takes like it takes a lot of money, and it will take about 10 years for that to happen. But if you're developing medical devices, that often takes a lot shorter time. That's closer to 5 years rather than 10 years, and even sometimes in some cases it can be even shorter than that. And then on top of that, as I mentioned, there are opportunities to deploy things without going through FDA approval that can still have impact on patients, and also helping pharma get drugs to the FDA and into the clinic. That could also have impact in a shorter period of time. So there are ways to have impact in a near-term fashion, and I think that's kind of a misconception that I really want to like dispel, that you have to wait 5-10 years, because I think a lot of people are like, I could just work on coding models and it'll be used by people in like 6 months, and that's like a much shorter term impact. But AI and medical AI it's going to be a little bit longer than 6 months, obviously, but it will still be it can still have impact in a fairly quick period of time. And so that's what we're hoping that we can get to that stage very, very soon as well. So yeah.
Okay. So yeah, let's go to questions from the audience. So what are the biggest barriers to deploying AI models, like building AI products in real world settings, in your case for medical AI?
It's a good question. So I will preface this by saying, we still haven't reached that stage yet, because we're still doing a lot of we're still on the research side, and we're starting to get to that commercial stage, but we aren't there yet. But based on what we've seen and the conversations that we've had with people in the space, I would say there are various challenges in terms of building out there's a lot of infrastructural problems, I would say, in terms of and also tooling problems as well, in terms of actually putting the models in workflows that the doctors can actually use. That is often a big problem, and especially the sorts of outdated software that a lot of these hospitals have. And so getting these AI models to be deployed in these sorts of outdated environments and in a workflow that a doctor will actually use can still be quite a hard problem. So that is one challenge, I would say. Obviously, depending on the use case, regulatory challenges can be an important consideration as well. So that is important to keep in mind. Um, but for what it's worth, I think the way we function as a company is because we're focused on this sort of foundation model level. We're less, we are developing the models that are put into these applications, and so other companies can build these sorts of applications or whatever, and they can use our models to do that. But we're not necessarily building all these applications ourselves. We would partner with other companies to basically build these sorts of applications. And so, and the nice thing about being open source, for example, is that it makes it a lot easier for, on the regulatory side, for example, we can be very transparent about how we train our models and the data that we use and so on. And we can give that information to the companies that are building the products on top of our models, and those companies are going to go and get FDA approval with our models. And we don't have to necessarily go through the FDA process ourselves, but we have all the information because everything is open source. So when the FDA does need to look at the model side of things, that is available for them to see. So yeah, those are some of the challenges. Then of course, another big challenge, of course, is data. That's a challenge basically. Any field experiences, and in the medical field, that also is a big challenge. Because of course, you have to be careful. Hospitals are not just going to freely share data because it's got personalized personal health information and things like this. And so again, when we are able to structure this as a collaboration with a lot of these medical centers, that becomes a little bit easier to share some of this data. But there are still some actual practical challenges when it comes to sharing data. You want to make sure you have to anonymize all the data, and so that can sometimes take a lot of time and take a lot of effort. But it turns out people are doing a lot of research into using AI to help also anonymize some of these some of the data as well. So that's a big area of research, and there are some tools that are being deployed for these sorts of things. So we can even help out with some of those sorts of things as well. But yeah, data can be a challenge to get that. But I think we are structured the way that we do research and the way that we are building our models in a way that makes it a little bit easier to address those challenges as well.
Okay. Yeah, I think we are out of time. Anything else that you want to add, to advertise, to any plugin that you want to say?
Yeah, no, I mean, I think I'll mention that we are hiring. We are hiring for AI researchers. So if you are an AI researcher, especially self-supervised learning is a big area that we're focused on. So if that's an area you are working in, or another area that we're working in right now is LLM post-training, so post-training open source models for medical use cases, so that we're doing a lot of research there. So if you're in both of these spaces, we're actively hiring. But also if you're just interested in medical AI and you have experience in AI research, we're not limiting ourselves to those two areas. But so if you're interested in general, feel free to contact us. On top of that, we have our broader medical AI research community. Feel free to join that. The link to that is medarc.ai, MEDARC.
We will put links in the description of the episode. Yeah.
Yes. And so basically it's basically a Discord server, but we have a bunch of research projects that are organized in the Discord server, and we have weekly meetings and so on. And so feel free to join the Discord server, check out the research that we're doing. All of our research is open and transparent. And so if there's interesting projects, feel free to, projects that interest you, feel free to contribute. And yeah, also feel free to follow Sofont and Medark and myself on Twitter and LinkedIn and all the different social platforms. And we share updates on our research and our progress very, very frequently.
I just have to
Sounds good.
quickly Yeah, I have to quickly observe the funny names of all the companies. So, you go on Discord to go organize with everybody. Go on Slack to go get your work done. You might as well just change the name of your company to like Postillions or something, right?
Yeah, I know. It's always the opposite, right? Like the joke is OpenAI is not open, and,
Yeah.
and mid journey is not mid, and it's just like the opposite name, right? So I should have come up with an opposite name for my company as well, I guess.
Okay.
Sick AI. That's what I call it. Sick AI.
Anything else that you want to say, Ellen?
No, it's been a pleasure to have you, and I used to be blissfully ignorant of healthcare AI problems, so it's really great to speak to somebody who's doing great work with. I mean, few people in AI research can be so sure that what they're doing is morally good as people like yourself.
Yeah, thank you. I hope you all learned a lot, and thanks a lot for having me.
Thank you so much. Thank you.